Hello, I'm Dr. Tim Benke. I am a pediatric neurologist at the University of Colorado and the medical director of the Rett Clinic at Children's Hospital, Colorado. I'm going to talk to you today about symptom management in CDKL5 deficiency disorder, A to Z, that is everything minus the epilepsy. So these are my disclosures, things that are relevant to the talk today. And I'm going to talk to you today about a symptom profile, consensus regarding treatment, some standards of care, and severity measurements. So what are the top 3 symptoms in CDKL5 deficiency disorder? Well, from 2 surveys, one from the NINDS supported natural history study. This is courtesy of Jeff Newell at Vanderbilt University. The top 3 symptoms are seizures, communication, and sleep. From the FDA-sponsored patient-focused drug development workshop, the top 3 symptoms were global developmental delays, seizures, and GI issues. So the question when these top 3 symptoms are developed, the main question I think is how is this information to be used? And one of the ways that this could be used is through development of therapeutic programs that, in this case, specifically say that seizures should not necessarily be the primary focus. But when you ask these questions, it really matters how you ask the questions. And whether or not you're in the top 3, it depends on whether or not you have the symptom. And also that depends on how old you are. In other words, you could have a symptom that's really important to you, but it may only be seen in a certain age group. And so there where you stand in these top 3 symptom type concerns, that'll depend on whether or not you have the symptom. Another important question is how close are the rankings? Were seizures, communication, and sleep all really closely tied, or was one really more ahead than the other? I think these are important questions because it's related to some of the things that we're going to talk about, specifically whether or not some symptoms are more prevalent than others, can influence how you rank them and how you treat them. And I think this is an important survey that should be considered in the future by the network that I'm involved in, which is the ICCRN, and I'll tell you more about that later in the talk. So standards of care. When you're developing standards of care for any disorder, these can be either consensus or data-driven. So consensus it's based on experience and opinion. And these opinions are often informed by experience in similar conditions. Data-driven means that there's data that specifically says how often a symptom is present in the population. And this sort of data would account for age and other factors. And then data also demonstrates that a treatment effectively treats a symptom. Similar approaches for this have been developed in Rett syndrome. So as part of this consensus approach, Dr. Sam Amin at the University of Bristol, we partnered together and he developed a survey monkey type survey that went out to 45 international clinicians that were familiar with CDD. And consensus was considered if more than 90% agreed. Sam's been working on a manuscript with this. So the results of the survey monkey are as followed. First is that individuals should be enrolled in a registry. Now there are a number of different registries that are available out there, and no particular registry was identified, but everybody should be in a registry. Regular developmental assessments should be performed. There should be a regular measurement of growth parameters. There should be regular assessments of swallowing. There should be a referral and regular assessments by GI and nutrition specialists, and consideration of gastrostomy if swallowing fails or there is a plateau in weight. There should be screening for osteopenia, that is for brittle bones. Hip and spine x-rays should be performed if clinically indicated. There should be referral to a respiratory specialist if there are concerns about breathing and breathing function. There should be regular follow-up with a neurologist and epilepsy specialist. Some of these evaluations should include a baseline evaluation of an MRI of the head, baseline EEG. Future EEGs should be performed to capture spasms or spells of unclear clinical significance. There should be consideration of CBD, vagal nerve stimulator, and epilepsy surgery. Screening and treatment of movement disorders should occur. Information should be provided about SUDEP, which stands for Sudden Unexplained Death in Epilepsy. An electrocardiogram or ECG should be performed at baseline. A regular skin checkup by your primary care physician should be performed. There should be referral and annual follow-up by a neurorehabilitation specialist. There should be referral and ongoing management by occupational, physical, and speech therapists, and there should be an assessment for augmentative communication. There should be regular screening for urinary retention and infections. There should be regular assessments for sleep, and melatonin can be used to treat sleep. Should be regular assessments for cortical vision impairment, or CVI. There should be provision of educational accommodations. Should be a hearing test at baseline. Should be regular dental checks, and there should be regular family financial support review. But these are all items that came through this consensus questionnaire. There weren't necessarily treatment recommendations other than those mentioned. So we've formulated primary care guidelines for Rett syndrome, and these came out in 2 papers that are shown here. And there's also links to these 2 publications on the screen here. I suggest that we consider using these for CDKL5 deficiency disorder for the time being, because there's significant overlap in the approach with regards to the different symptoms in Rett syndrome and CDKL5 deficiency disorder. I think both of these papers are quite useful, and that I would say that because I was an author, but I think both of these papers are quite useful if you provide a copy to your primary care physician, because they serve as a checklist such that all of the items on the checklist can be followed on a routine basis. One of the things that is pointed out in these guidelines that's useful for you to keep a healthcare information binder. You can put these papers in the binder, and then whenever you see any physician, any of the results from those visits should be put into the binder. Having these papers there as a checklist, it serves as an important reminder to you and your physicians about what needs to be done on a regular basis. So one of the ways to look at these is when I put all of these things together in a table, they're also present in those papers, but I wanted to go through each of those items as part of this discussion today. So I think a yearly physical by your primary care, and consider the use of the Rett syndrome guidelines for now. I think that it's important that we come up with CDD specific guidelines in the very near future. As part of your primary care visits, your primary care physician should be following your body mass index every 6 months and follow the feeding patterns. Useful guidelines: if it's taking more than 30 minutes to finish a meal, it's likely that if this carries on for a period of time, that weight will plateau and there may be the need for a gastrostomy tube, and necessary referrals may need to take place as part of that. Your primary care will be referring you to specialists. And I think it's important to be seen by a center of excellence every 1 to 2 years. A lot of times the center of excellence isn't available, and so that's why the guidelines were created for Rett syndrome, such that your primary care can work with the specialists that are available in your area in a way that suits you and your family best. For neurology and epilepsy, I think a prolonged EEG is necessary for spell capture. We all know that in a small number, it's less than 50%, it's probably about 20 to 25%. There can be a honeymoon period. This is when seizures abate for an extended period of time. Our rule of thumb, and I know that you just have heard a talk regarding epilepsy, so I won't go into this too much, but I think a maximum of 2 anticonvulsants unless you're transitioning to another one. And these came out from the consensus is to consider the ketogenic diet, vagal nerve stimulator, and CDB. Counseling should happen with regards to sudden unexplained death and epilepsy, and counseling and management should happen with regards to sleep. Your neurologist may help diagnose and manage things like chorea, stereotypy, Parkinsonism, and dystonia. For therapies and rehabilitation, these should be instituted at the earliest possible time. These should be lifelong and should include physical, occupational, speech, and augmentative communication therapies. Supports such as braces, splints, things that help with mobility such as standards and other equipment for the home need to be considered. For vision, yearly screenings for refractive errors, and I think early assessments of cortical visual impairment should begin within the first year of life. One of the things that I recommend is that these should be evaluated by an ophthalmologist. This ophthalmologist should be familiar with cortical vision impairment. Those that aren't familiar aren't likely to make the diagnosis of the referral. And I think that the reason why this is particularly important is that a teacher of the visually impaired needs to then be involved with classroom accommodations. In other words, if a child has cortical visual impairment, then things in the classroom and how the child is taught need to address this with CVI in mind. For GI and nutrition, the body mass index needs to be followed every 6 months. If there's difficulty swallowing, then a swallow study should be considered. And this is an indication as well as a plateauing weight for gastrostomy tube placement. GI needs to manage reflux and constipation. And there needs to be monitoring and replacement as needed for calcium and vitamin D in order to prevent broken bones. One of the things that I suggest, and it's done differently in different places, is that a vitamin D level needs to be obtained initially on diagnosis. If it's less than 40, then replacement needs to be considered, and then it needs to be followed on at least a yearly basis. For cardiac, a yearly electrocardiogram needs to be used to screen for prolonged QT. If this is abnormal, and certainly if there's any other abnormalities, these need to be referred to a cardiologist. For orthopedic concerns, there needs to be a supine examination of the spine after 4 years by the primary care. Sorry, there's a misprint there. It should be a prone examination of the spine after 4 years old by the primary care. If there's scoliosis more than 10 degrees, then this needs to be confirmed with an x-ray and then followed every 6 months by an exam. We suggest referral to an orthopedist to consider correction if the curvature is greater than 45 degrees. For your pulmonary specialist, but also for your primary care, there should be a screening and questions for frequent pneumonias. And if these are occurring, then consideration of swallow studies and possible gastrostomy tube if frequent pneumonias are taking place. I think an influenza vaccination should happen yearly. As I said, refer to a pulmonologist for frequent pneumonias. And then COVID vaccinations should be considered once they're approved, depending on the age, for both the individual as well as family members. For dentistry, deep cleaning should be considered every 6 months. For genetics, I think a genetics referral with genetic counseling should happen upon diagnosis. And there should be parental testing if missense mutations are present. For the family, I think age-appropriate activities are necessary along with socialization and schooling. Family respite needs to be considered. Clinical trial awareness is very important. And I think a lot of these can happen through the assistance of patient advisory and support groups. For school, an educational plan with all therapies and vision accommodations needs to be in place. Children should be included and activities should be age appropriate. So how is severity assessed? and this is an area of discussion and research. So we developed the CDKL5 Disorder Severity Assessment. And through a new grant from the NIH and the National Institute of Neurologic Disorders and Stroke, we're now developing this further. So the CDD Severity Assessment has been divided into 3 portions now. There's a clinician-reported measurement, a parent-reported measurement, and a developmental questionnaire. And the papers at the bottom there note the initial development of the severity assessment and a recent content validation it is now in press in Journal of Child Neurology. So what are the intended uses of these severity assessment? Well, primarily, we want these to be able to measure significant change in a clinical trial, but it's also possible that these could be used to measure change as your child is being followed by your clinicians. There are several very important next steps as part of these severity assessments. The first one is reliability testing. In other words, if I use this today and in 4 weeks' time or 2 weeks' time, will I still get the same answer? If I use this and another clinician uses it, will they get the same result? Also, validity testing needs to be performed. That is, are all the questions performing the way that we want them to? And we're also in the process of making training videos such that other people can see how we administer the severity assessments and see how we score them as well. Other measures as part of our NIH-funded effort include measures of hand use, sleep, gross motor, communication, disability, and we're also evaluating biomarkers through EEG and evoked potentials. Our next steps with each of these are reliability testing, validity testing, psychometric validations and correlations, and we're also doing training videos with all of these items as well. So we hope that you'll stay in touch with this. These in the United States involve 8 sites, and we're also part of our group also is the group at Telethon, and the contacts there are noted for each of those sites. And you can also find out more information about this on the web as we develop these severity assessments and move forward. So that's what I have to tell you today. It's a short talk, but I hope that you'll spend some time and send some questions to the team through chat, as I believe Antonino has outlined for you. But I want to especially thank all people and families with CDKL5 deficiency disorder, also my Rett Clinic team, Scott, Margarita, Tristan, Katie, my NIH, UO1, and ICCRN collaborators, Helen Leonard and Jenny Downs at Telethon Kids, the partners of the NIH Natural History Study, Eric Marsh, Alan Percy, and Jeff Newell, of course, Sam Amin at the University of Bristol with all of his efforts in developing consensus, and different funding sources also noted there as well. So as mentioned, for any questions, please use the chat feature or email me at my email address here below. Thanks very much for listening.